Okay. Again, I want to reward and I thank all of you who've logged in here to listen to this really great webinar we have for you today. My name is Naftali Serrano. I'm the Executive Director of the Collaborative Family Healthcare Association. Before we get going, we'll do the usual sort of house cleaning stuff and announcements related to this webinar and other important things connected to the webinar. So just a couple of things here. You're seeing on the slide here, obviously our sponsoring organization, the Collaborative Family Healthcare Association. And this webinar is sponsored specifically by our Primary Care Behavioral Health SIG, Special Interest Group. So if you are not a member of the PCBH SIG and you like what you hear today, this is an opportunity for you to get plugged in and connected to that special interest group that focuses in on promoting the use of and evidence behind and supporting the workers of who work within the primary care behavioral health model. So if you're interested in that, obviously that requires signing up for membership with CFHA. You can go to cfha.net. If you're already a member and want to become a part of the SIG, it's really easy. You just log into the website and go to your profile. And in your profile, there's a checkbox that you check whatever special interest group you'd like to join. So you can select the PCBH SIG, for example. There will be some upcoming webinars that the PCBH SIG is also sponsoring, so keep your eye out for those as well. Now, a very specific date you might want to keep in mind is June 26th, because the PCBH SIG will have a meeting 4 to 5 Central Standard Time. That's 5 to 6 Eastern Standard Time. I always have to do that translation for myself. And what's really cool about this call is that they're going to be featuring a focused article review, and the author of the article will be present to discuss their article with SIG members, so it's very interactive. And so the article will be sent out weeks prior to the call, so keep an eye out for that email on the listserv. All right, the other key piece is, of course, ensuring, and Liana, you can move forward here with the slide, is just reminding you about our annual conference, which is another opportunity for PCBHers and folks who work in all kinds of iterations of integrated care models to come and be stretched, to learn, to network, to have fun, to be re-energized at our conference in December, October 17th to 19th. So we want you to join us there. And the PCBH SIG in particular is having a get-together at that SIG, at that meeting as usual. So it's another opportunity for you to really get connected professionally and to be with like-minded individuals. All right, the last thing I'll say is that all of our webinars are available on integratedcarenews.com, our news website. So check integratedcarenews.com for this recording, and probably we'll be able to post it in a couple of days, and it'll appear in the videos section of the site on our video stream. All right. Last but not least here, the usual webinar housekeeping that you guys are all familiar with if you've been to a webinar before. We're going to spend the first 45 minutes with the content that Mary Jean has, and then we're going to have some time for questions. Feel free to use the chat function as you go to ask questions, and we'll try to aggregate those questions and have Mary Jean address those. So, Liana, you can switch over to the presentation. And I want to thank Mary Jean for her willingness to present with us today. Mary Jean is one of the kindest people I've met. She's just wonderful to work with, incredibly professional. And what I most appreciate about Mary Jean is how much sort of pragmatic experience she has as a program developer in her health system. And also as a consultant, helping other people figure the pragmatics of making integrated care work out She is a great resource for you and for CFHA. So without further ado, Mary Jean, thank you for doing this, and we look forward to the conversation.
Okay, thank you, and thank you for inviting me to do this. Oddly enough, I really like talking about reimbursement for integration, so I hope that some of the people listening also enjoy the topic and continue to learn more. Let's go to the next slide. To talk about the objectives, because we have a lot here. And I want to preface this by saying there's way too much information in this webinar. It's not intended that everyone will take in all the information today. Some of you may be really new to this work, and you're going to take in some information, but I put a lot into the slide because I want you to keep this as a resource. And I've also linked to other resources. So if you're new to this, consider this a kind of a seed for you. And if you're an old hat with this, feel free to make sure I'm keeping things on track and saying the right things. And hopefully you'll learn something as well. So we want to talk about the basic rules and regulations that guide our billing and coding for integration. Definitely talk about resources throughout the presentation. We want to talk about value and how integration is being looked at, not just for meeting the bottom line, but some additional ways that we can look at value. And then some key ideas and steps that managers can take to sustain this model. Next slide. When I say sustain, it gets to that goal. All of you, no matter if you're a BHC or a supervisor or a manager or director, should be really clear about your goal for this work. And we've had this goal for a long time in our program, and sustainability is the way that we would talk about the financial piece of it. Clearly, sustainability has to do with other pieces of the operation, but it's kind of a nice way to talk about the funding. Next step. Or next slide, sorry. Throughout the presentation, I'm going to go through some 10 tips for success. And I'm not going to go over them right now, but you'll see them throughout the slide. Next slide. Our lawyers always have me do this disclaimer, but it's important. Basically, I'm going to give you the best information that I have today. I love questions. I love being told that I've missed something and that I learned something new. So, but just know this is the very best information I can give you today. Also, don't base any of your actual billing on what I say without going to your own billers and coders and auditors and legal, etc. in your own organization. Next slide. Next slide, please. Oh, I'm sorry, go back. I put this in here not to go over it, but to give you, to just remind you, anytime you're going to talk about your integration program, make sure that you always say why integration. Now, you may assume that the audience is aware of that and it's kind of a no-brainer why it's useful and important, but put slides like this into any presentation, even, and it's maybe especially if you're talking about the money. But as you see in the slide, the increased cost efficiency, we're beginning to get some data, some research that looks at the cost efficiency of BHI. So that becomes more and more important as you're trying to justify the cost of your program. Next slide. So the first tip is to know your service and the business model. And I'm an LCSW by training. I'm an old social worker is what I say. And so I never got my MBA, to be talking about a business model always feels a little odd. But then every once in a while I sit back and go, wow, this is working. And it's because I worked with our CFO and other financial people to come up with a business model that works for this. So so think in terms of both your service model and your business model. And to do that, you need to know the level of integration you're aiming for, what type of practice setting will be doing the billing, and where you're going to do the work. Next slide. So this is the typical levels of integration that was initially developed in 1996 by Baird and others to go from coordinated to integrated. And the National Council added the 6 levels. I'm going to really focus on co-located and integrated. And what I did is I took the levels and then added the reimbursement information to them. So when you go into this, know how you're going to set this up from your business model. Are you going to be a co-located where you have a separate mental health agency doing the billing embedded in your primary care or medical practice, or is this going to be fully integrated with a medical practice doing the billing? Next slide. And we use this slide all the time just to show people that it is different. Many of the organizations in our state about 25 years ago plunked a social worker into a primary care practice and took all the risk on themselves. Just said, well, if we can be in an outpatient mental health setting, we can just sit in primary care and do the same thing. It didn't work. It didn't work because all of the risk was on the mental health person and agency, and they just tried to replicate that work rather than really integrating the service into the medical practice and having the medical practice take on some of the risk. Next slide. So there are kind of 2 basic models. One is the co-located model, where a behavioral health clinician, either an individual or organization, partners with a medical practice, and the behavioral health clinician or agency does the billing for that. And there could be things that the medical practice offers, like scheduling and free rent and access to patients, but more of the financial burden is on the behavioral health organization. And there are reasons that folks do that. An integrated model probably has the medical practice do the billing, and they probably contract or employ the behavioral health clinician. You just want to know upfront what your setup is going to be. Next slide. So lots of questions to ask. And if you're new to this, you don't have to have all the answers. You just need to know what the questions are. So who's going to deliver this service? So you can have a master's level clinician, a psychologist, or a psychiatrist. And what codes will you use? Who will your partner be? Are you going to be a mental health agency and a medical practice, or something different? Where will the service be delivered? Will it be delivered in a FQHC or a provider-based practice? And I use those terms, and if you don't know what they mean, you will as you get into this work with your program. Who will employ the staff? And I use employee in quotes because it could be contract for the staff. And probably one of the biggest and most important questions is who will do the billing? And then from there, how will the reimbursement work and the insurance be billed, etc. So those are just a few questions you need to answer if you set this up, but there are answers. Next slide. So these are just some potential ways that people can partner. It could be a mental health agency and a private physician practice. It could be a mental health agency and a hospital-owned practice, or an FQHC, federally qualified health center or rural health center. Or the hospital system can have its own behavioral health program and they can partner within themselves. Or there are certainly places where private clinicians are embedded in a physician practice, and again, you can look at the financial model of who has the risk and who does the billing in any of those setups. The other simple thing would be that the medical practice employs the person directly. But as I go through and talk about codes and insurance and other things, it will be pertinent to any of these arrangements. Next slide. So I've said this before, in my mind, the ideal way to do it is to share the accountability and the risk, including financial risk, between if it's 2 organizations, between the mental health, behavioral health organization and the medical practice. Again, because many of us tried to do it differently and it failed miserably. So that shared responsibility really makes this work. And it also helps it to be more integrated. and have financial success, where the medical practice does the registration and the billing, and the behavioral health clinician is contracted or employed to them. When you're going, if you're new to this and people are saying, well, you know, are you going to be able to break even? We were able to come up with a 3-year financial plan, which allowed for ramp up the first year. So as you're thinking about that, the first year is the toughest year to get this started. But if you do a 3-year plan, likely you're going to show much more financial positive over the time. So as you, again, think about that shared responsibility, think about a ramp up period. And then your job, if you have this partnership as a supervisor for the BHCs or even the BHC, is to maximize your reimbursement within whatever setting you use or whatever setup you use. Next slide. And then there are these problems. I always use this little piece of clip art because it looks so much like our old CMO. And he felt this way when we first started doing this work. But it's difficult. The regulations and the licensing don't really match primary care settings. They were set up for separate mental health agencies and not for integration. There's a lot of lack of clarity and understanding about how this works across the board. And licensing sometimes gets in the way, documentation, and a lot of inconsistent expectations from everyone. So just be prepared for that. It's the nature of the work. Next slide. So the basics, learn the basics of coding and reimbursement. And for those of you relatively new to this, just focus on this part. I'm going to give you a lot more information, but if you get the basics down, you're 80 to 90% there. Okay, next slide. One of the basics is who gets to, which type of clinician can be paid for what. So master's level clinicians, Medicare only allows LCSWs to be reimbursed using the mental health code. They don't allow LCPCs. And I'm using LCSW as the fully licensed MSW level. I think some places it's LISW. But LCSW, LCPCs, Medicare still does not allow that, even though every year I think they try to institute some legislation that would overturn that. But just keep that in mind. Medicaid is state by state. Our state is much more liberal. It allows LCSWs, LCPCs, LMFTs, and even conditionally licensed people. But you need to find out what your state Medicaid allows for reimbursement. And then the commercial insurance are also maybe more variable, but tend to restrict to fully licensed staff. And so that would be LCSWs or LCPCs. I'm not so sure about LMFTs. But again, you're going to need to find that out as you start contracting with the commercial insurance. Psychologists tend to be better, more universally reimbursed. And so Medicare reimburses, and these are clinical psychologists, not master's level psychologists, but clinical psychologists. In addition, they can be reimbursed through Medicare for the health and behavior codes. And I will talk a little bit more about that as we go on. And then second Ps or PAs are use the E&M codes. They're generally paid by all insurers, but would not use the health and behavior code. Next slide. So these are the basics. The mental health codes are for master's level clinicians, not medical, not psychiatry. You would use a 90791, which is an initial assessment. I'll go through some of the pieces of that later. In individual therapy, you see that there's a 30, 45, and 60 minute code, but you can see the minute range there. So bottom line, this comes up a lot. Can we get paid for a warm handoff? Generally not, because generally it's not going to take 16 minutes. So you haven't met that threshold for an individual treatment code. Then family therapy should not be less than 26 minutes, and then group treatment. Next slide. E&M codes are, again, for psych MPs or psychiatrists. They generally use the 90792, which is an initial assessment with medical services. But as you can see here, second Ps or psychiatrists are also allowed to add on a psychotherapy code to their E&M code if in fact that's part of their service delivery and they're not just doing that med management. Next slide. For E&M codes, they also use, not unlike primary care, a new patient 99201 or a follow-up patient 99211 code or 99215. They have to follow the rules for complexity for their coding. I'm not going to go into a lot of that. They need to be medically necessary and within the scope of services, and generally in conjunction with medical or psychiatric diagnosis. The second, NPs tend to know the rules about the E&M codes. Again, so not going into those. Next slide. I don't pay a lot of attention to this, but I think it's worth noting, especially I think for psychologists, this is nice that they are reimbursed at 100% of the amount through Medicare that an MD or DO is reimbursed. Second, Ps or PAs at 85% and the LCSW at 75%. Next slide. So as I said, Medicaid differs state by state. You will want to find out what mental health services are covered, and that, as I have a slide later on about other codes, and those tend to be the ones you have to really check. Are they on the fee schedule for your Medicaid state? A question that used to come up a lot is, are you allowed, will they pay for two services on the same day, a medical and a mental health service? For rural states like ours, this was really important because people wanted to come and get both services on the same day. Initially, when people started looking at this, maybe 8 years ago or so, it was not as, there were a lot of states not allowing two services on the same day. My hope is that more states are doing this right now. Medicare also does it. There are some rules around it, but it's, again, worth you finding out about your state. And then some of you have contracted managed care with specific rules. Like most places, it requires the diagnosis and the code, and they may limit some procedures. So you may, in your state, Medicare may allow some things and Medicaid may not, which makes it confusing. Next slide. Then there's commercial insurances, or the carve-outs. One of the things that is new to medical practices, if they're going to do the billing, is credentialing or enrolling your staff in the behavioral health carve-out. But this is an important piece as you start the work. They may tell you that there are too many LCSWs or LCPCs in their area and they won't credential them. A hint is that we have then gone to a large employer, asked them to advocate for their employees and make sure that staff get credentialed. It has worked on at least one occasion. There's always lack of clarity. It's difficult to find experts. The different commercial insurances have different expectations. So just know that up front. What you're going to want to do is, in any primary care or any medical practice, there's probably somebody who sits at that front desk who becomes really good at this kind of stuff. They know who to call, they know when you have to do the prior auth, and they're able to get this work done. And I would say find those people in any practice you work with. Next slide. So what are the codes and the other codes? I talked about that. So I just covered the main code. There really aren't that many. But now let's go to the other codes. Next slide. Health and behavior codes are used for medical diagnosis when the BHC is working to impact the behavior that affect that medical diagnosis. And so these are the codes. There is assessment, reassessment, and treatment code. The group code isn't covered by everyone. So even though it's a perfect thing to do for, let's say, a group of patients with diabetes where you're working on their behavior change, it isn't always covered. Next slide. So what you need is the patient has an underlying medical condition. There are biopsychosocial factors that affect this. And you have to say in your notes that the patient has the capacity for this work, because it's a CBT type approach. So they used to require the physician document that they need this. Now I would say referral from the physician is across the board useful. And you cannot use health and behavior and mental health at the same time. So you could be seeing with someone, let's say they have asthma, and you're working on their some behavioral change to make the environment better for them, and you find out they're really depressed. You just switch to the mental health code. Next slide. So I just give some examples for folks to think about this. Next slide. I'm not going to go into all the ramifications. The difficulty is for master's level social workers that Medicare doesn't pay, so it's really hard to figure out how to deliver this service when you really aren't supposed to deliver a service based on the funder. There are some tricks to that, but again, there are whole webinars we can do on the health and behavior codes. Next slide. This is a slide I want you to keep on the documentation for health and behavior codes if you're able to do this. Our folks find that it's way easier than mental health code documentation because you literally don't need a treatment plan. You just need to have a goal with specific objectives around the behavior change. Next slide. Crisis codes, I think, are relatively new codes, and they're used when you're assessing someone for suicidality or some other major risk situation. So let's say you're in a practice and all of a sudden there's a patient there in crisis, and you're assessing how do they need to be hospitalized, and you're maybe even facilitating the hospitalization. It can take a lot of time, and it's very focused. So these codes really spell out what you need to do for these codes. And please note that I took this information from another webinar. I will also tell you to do that. When you see webinars, keep them because you're going to go back and use those for reference. But the 90839 and then the 90840 is an additional chunk of time that you would add to the 90839 if it is extended period. We've had staff who spend 2 hours on a situation like this, and then the crisis codes are best used. Next slide. This is just more on that, and again, keep this as reference. Next slide. And speaking of complete webinars on information, I'm not going to go into the collaborative care codes other than to state that the AIMS Center at the University of Washington has all the information that you need to understand a bit about the collaborative care codes as you start using them. Basically, it is a way that primary care bills Medicare and some other insurances to get consultation from psychiatry and to have a behavioral health care manager interact with the patient and help make that connection to improve the care of the patient with some kind of condition that the psychiatrist can support. Next slide. This just shows, this is, it may be outdated, but this is the type of money that you would get with these codes and then how the codes work. So it's kind of an example of it. Next slide. And these are the references. Most important, go to the AIMS Center, see what they have, and investigate further. Next slide. So some other codes that we're beginning to look at, the prolonged evaluation management codes. Our psychiatrists do some very thorough consultation, and they're spending a lot of time reviewing records. These prolonged E&M codes can be used in conjunction to seeing a patient face-to-face. We're just beginning, but I would propose you guys look at those. Interactive complexity we do not use, but I think they're out there for folks where this might be a good match with your population. Definitely look at that. Multifamily groups, while a wonderful way to treat folks, it is not, that code is not always accepted. And we have been working for 3 years to figure out the smoking cessation codes and how to get paid. And we're not there yet, but I support anyone who figures out how to get paid for that, from their BHC. Next slide. I'm just going to mention this thing. We used to call them fiscal intermediaries, and they're MACs, but they're local. They're your local service organization that translates the Medicare or CMS rules to what you need to do for reimbursement for Medicare. So they provide education to us as providers for fee-for-service, and then they also establish local coverage determinations, which are basically their interpretation of the rules. National Government Service is our MAC. It is a MAC for many of the states, but you're going to really want to know who yours is and then get on their distribution list, because they change things and you're going to want to see the changes. Okay, next slide. So this is probably where I should have started. And this is where you need to start with your staff. You really want to tie the reimbursement to their clinical service delivery and their documentation. It's really about, the good news of all of this is there is some logic to it. Next slide. The other piece of good news is there aren't a whole lot of documents. There are three: initial assessment, your treatment plan, and your progress notes. And you need to document medical necessity. Medicare is really clear that your progress notes are not psychotherapy notes. And if you aren't clear, I would really direct you to go into the Medicare rules around mental health billing and read about that. And I think the difference for me in my head is psychotherapy notes are like the old process recordings we used to have to do. Progress notes are really very cut and dry, especially in integration. You know, what's the goal? How's the patient doing on that goal? And what's your plan for the next step? Next slide. Your initial assessment, again, you can keep this slide as a reference. It's pretty much the standard initial assessment expectations. I would say for me, one of the important pieces is your initial plan of treatment. So it's your formulation, but also what do you plan to do with that patient? Next slide. Treatment plan. We have had the wonderful opportunity to be audited by Medicare in one of our regions, and we've learned a lot. One thing we've learned is they really care about treatment plans and integration. And so as you know, treatment plans need to be individualized. They need to say the type of treatment, the amount of treatment, the frequency, the duration. Link your treatment plan to your diagnosis, have your goals and specific individualized objectives. And what the important thing is to get that treatment plan done early in treatment. Medicare says that you do not need a treatment plan for a few brief sessions. The problem there is you think you're only going to do a few brief sessions, all of a sudden it's the third and the fourth session, and you don't have a treatment plan. One might say, well, what are you doing without a treatment plan? Because it should guide your work. But Medicare will say, I won't pay you for that without a treatment plan. So we're now saying, do your treatment plan the first session after your initial assessment. Next slide. So then I've gone over the time frame for your therapeutic, the individual therapy, family therapy, and group therapy. For group, the notes for that can actually, the progress notes can be pretty simple. You do all the pieces like diagnosis, etc. But generally, I have one paragraph for the group about what the group focused on, and then an additional paragraph about that individual and what they did within that group. Next slide. Progress note. I know this looks like a lot. You don't have to say a huge amount in your progress note. You need to tie the work to your treatment plan and your diagnosis, and you need to have a sense of what the patient brought to that session, and then what your plan is post-session. So it doesn't have to be a lot of information, but definitely has to be tied to the diagnosis and the treatment plan. Next slide. So I know this feels like Stop the Madness for questions. I'm not going to do that yet, but every once in a while you have to just tell yourself, this is madness. It's okay. We're going to get through it. So I'm going to go into some next steps of ways to go through it and ways that you can manage all of this information, especially if you're new to it. Next slide. Organize your information. How about a grid? Next slide. So when we first started, we just developed this grid, which says, what's the code, who can do it, a little bit of information about it, and then at the bottom, in which settings can you use that code. Next slide. Then the National Council and SAMHSA developed one of these for each state. The good news is they developed one of these for each state. The bad news is they were done in 2011, and I don't think updated since then. But it gives you a sense of how to organize the work. Next slide. Even better, Oregon just created this grid, and I put the link at the bottom. I would strongly recommend that you go in there. They have way more codes than we're able to use. Remember, states are different, but it's a really well-organized grid, and it has a lot of good information for those of you starting in this and for the basics, like what Medicare would expect. So really good way to organize it. I have a few slides on this. You can go through those. Next slide. Next slide, next slide. And this is sometimes how it feels. It's okay. Again, you're going to create your own grid, and I would say once we created the grid, we didn't use it that much. Just creating it helped us organize our thinking. Next slide. So this is probably one of the most important tips that I have for you. And I actually heard it at CFHA probably almost 8 or 9 years ago. And I thought, well, that's a weird thing to say, make friends with your billers and coders. That was so weird. I would say this has proved to be over and over and over and over really important. So next, and I don't know if you'll ever get to the point of dancing with them, but if you feel that way, that's really great. Next slide. So who do you go to for help? Because you cannot do this on your own. You definitely cannot do this on your own. And you need to partner with your billing and coding supervisors. We have at least one region where we had big fights with them. And now we're friends. So we are dancing with them now. But it wasn't fun when they were disagreeing with us and they had their own view of things. It's so important that if you don't presently like your billing and coding supervisors, you got to move past that and become friends with them. If you have internal auditors in your organization, sometimes you have to teach them how to work with you in auditing your integrated clinicians. But once they learn, they are a fabulous resource, really, really helpful. If you have integrated policy groups in your state or any kind of work groups, join them and really connect with anybody who knows what they're talking about, wherever you find them. And people will send me webinars or PowerPoints about reintegration or reimbursement, and I'll sometimes reach out to the author and ask a question, and I'm always so pleased that people get back to you. So there's not a whole lot of ego in this work. People really want to share the information because it's hard. Next slide. So one way that we were able to do it early on is we pulled together, when nobody really knew what we were doing, about when we first started, we pulled together a work group with biller and coder supervisors, program supervisors, psychiatry, auditors, and we all really crunched our brains together to figure this out. Again, extremely valuable. So we can come to common understanding about the rules as well as the barriers. And I would say also, we made relationships with these people. So they trust us, we trust them, we can call them to troubleshoot things that come up. But if you haven't done that yet, I strongly recommend that. Next slide. So plan to get paid and evaluate your work. That seems so, of course. But when people first started with integration, they didn't always, they kind of planned to get paid, but they didn't watch it. They didn't monitor it. 6 months later, they found out they had done something wrong and they weren't getting paid. So plan on it, plan to make sure that's happening. Next slide. So part of it is when you hire someone, you know that there's going to be a lot to it. So before you hire them, be really clear about what your financial and billing arrangements are. And then as you hire them, you're going to start that credentialing and enrollment process to prepare for the billing. When they start, you're going to orient them to the billing and reimbursement process, and then you're going to monitor this over time. And again, this seems really logical and basic, but not everyone has done it, and then they've seen where they fell apart. Next slide. This is just a reference to, we have a startup worksheet that I'm happy to send out, so accept my email there. And if you email me, I'll send you a copy of it. Next slide. So once you've done that work group and you've started your program, the other thing we recommend is an administrative meeting, team meeting, or friendly forum. I worked with one organization, we did this monthly. We now in our program do it quarterly. And we sit down with our clinicians and the billers and coders and the practice management, and we go over our data on how we're doing volume and how we're getting paid. And we're talking about the barriers in the way, and again, we're coming to that common understanding between the clinicians and the billers and coders. I would say over time, people think they don't need this anymore. They need this because things come up, or new practice managers come on, or new issues come up. So having this forum is really useful. Next slide. Some of you are probably doing a great job of already measuring outcomes and having started, I've heard from some groups to really start with great metrics. It's hard, and some of us don't have as much ability to get to the data, but be looking at your volume, look at your no-shows, time to third, and the charges. Ideally, you look at collections too, but that gets way beyond what the BHC has control over. And then again, if you're able to get the clinical outcomes as part of this and financial impact, how much are the medical practices paying for this service, and how much are they able to reimburse themselves through reimbursement? Next slide. I just put this here. This is a sample of the dashboard that we use. It's out of Epic. It is it's exactly the same as what the providers have in Epic. We just added a few rows because we had some target productivity pieces in there. But this is the kind of thing we review quarterly with the practice management. Next slide. So some of you may have already had enough about reimbursement, and you're never going to learn anymore. I hope that's not true. But the rest of you, you're going to have to keep learning because it changes. And guess what? People know things. I have had to learn to be humble. Just recently, there are two experts in our larger organization. They know way more than I do about some things. I kind of hated that, but I was pretty excited that I learned some things. So be humble, keep learning, and be curious. Next slide. So in addition, keep your costs down because people are going to expect that. Aim for break even. Don't aim too high. Be careful of that. Look at if there's any way for alternative payment models. We've already talked about the importance with your linkage, your billers and your coders. I would also say pay attention to that front office piece and bring them in. Bring your front office staff into this discussion early on so that they understand why you're doing what you're doing, and then they can support it. Next slide. More reimbursement resources for you to use. Next slide. And watch for any webinars on reimbursement. They tend to have a core set of information, which is good over and over, that reiterative learning, but you're always learning something. Next slide. More resources. Next slide. So many of you are probably being asked, well, you know, what is the cost of integration? Can you break even? But we really want to change that question to what is the cost impact of integration. Next slide. And the question you're probably getting is, can behavioral health integration pay for itself? We really want to change the question to what is the impact of behavioral health integration on healthcare costs? really important stuff that I think there's more and more research that's going to happen and really support our work. Next slide. A couple studies referenced here. One is Intermountain, which says the more integrated the practices were, the more they were able to reduce unnecessary ED utilization. Another one where collaborative care, there's some good cost-effective slides of the collaborative care codes. Next slide. Another one that Intermountain did where an expenditure of $22 per member per year resulted in $115 cost saving per member per year. And imagine for thousands or hundreds of thousands of covered lives, that's a huge amount of money. Another one is they evaluated when the behavioral health clinician was in the practice, could the primary care folks be more productive? Yes. And they quantified that to 1,000 plus, which was a huge amount of money. And then the last one that is one of my favorite ones is it's looking at the percent of the medical practice panel that the behavioral health clinician sees impacts, and initially finding a reduction. The larger the percentage that they work with, the more healthcare costs are reduced. So good stuff. Next slide. So value beyond the bottom line. Provider satisfaction. Huge, huge, huge. Patient satisfaction, their ability to access behavioral health, reduction in PHQ scores, reduction in other indicators of chronic disease, reduction in ED use, hospitalization, rehospitalization, retention. BHCs like this work. It costs money to hire staff. Sometimes complex care wastes a lot of money and time, and BHCs can be helpful. And let me again say how important it is for provider satisfaction. And last slide. This is my contact information. Always happy to answer any questions people have, especially if you think I said something that doesn't jive with what you know. Let me know and make sure I clarify it. And now I think we have time for questions.
Wow, great job, Mary. To go through all of that information as well as you did, really, really great work. So yeah, we've got some time for questions and answer. I've been trying to answer questions as they come or aggregate them. There were some that were straightforward that I was able to kind of lop off. But one of the more recent questions was, could you give an example of an alternative payment models? I know you were talking more about present state, but I think folks are looking to the future. So maybe just some basics on capitated or bundled payment or shared risk type payments.
Yeah, I wish that we had something like that. We're in the bariatric offices, and ideally they should have a bundled payment where the practice would bill for the practice would bill for the procedure, and the cost of the behavioral health clinician assessment, which is part of that, would be included in that overall cost. There are probably some places where they are looking at ED reduction and having a way to be reimbursed as a system for that, and then the BHC work would be part of that. I don't know if Natalie, if you or others or Deepu have any examples. I wish we had more. We're not that sophisticated as an organization yet.
Yeah, I think that generally describes the way it's been sort of implemented in different areas. So, sometimes it's like what you referenced in a slide, that per member per month type payment. Sometimes it's an annualized payment, but oftentimes it's like $5 a month that's added on to the patient's care for behavioral health onto the medical costs, and the clinic has that amount to work with. And then there may be some incentive payments that are added on that the clinic can earn if they achieve certain outcomes in their population. Like, I don't know, 60% of their patients achieve remission for depression in the year, and they get $100,000 for that. That's the idea of sort of a bundled payment with an incentive attached to it.
Yeah, we have an example where we're just working with a cardiology practice, but another specialty practice is looking at their outcomes post-surgery when depression is part of it. I think they're going to prove that there will be cost savings if the depression can be mitigated, the cost savings in the overall health care of those patients.
So I have a really interesting specific question. Maria Arroyo asked, since it's not a medical condition, does fear of vaccinations count as factors affecting treatment? And so would an H&B code be able to be applied to the intervention?
The problem with H&B codes is you need a medical diagnosis. So let's just say the child had some kind of condition where the vaccination was really important. Then I think you could use the health and behavior code because you're impacting that medical condition. But for a well child, and this is such a good question because when people started this work, they thought they could use the health and behavior codes for a well child or the annual assessment, etc. They are tied to a medical condition. So I would say that would be the answer. If there's a medical condition the vaccination is important for, then you could do it. Without that, I don't think so.
Yeah, that was my sense as well.
Then you would have an anxiety diagnosis, and then you would use the mental health code. Right.
Yeah, that was my sense as well. All right. So another question here from Nadia Islam. I'll read it out to you. She's a psychologist in a pediatric primary care practice, and she's unclear on whether a psychologist can bill an E&M code. She's in Virginia and was under the impression that she could not bill E&M codes, so she only currently bills mental health and H&B codes. So maybe just first start clarifying that piece.
That would be my impression too, that E&M are medical codes. I've never had that question before, so like always, I will look it up to make sure. But my understanding is E&M are for NPs, PAs, DOs, MDs.
So the other sub-question she had, which kind of falls into a little bit more of the specialty type practice, is she does some testing. So any advice on billing for assessment and testing? She does some brief assessment, as do the pediatricians.
Yeah, I did not go into the testing codes here, so I can't. Sorry.
Yeah, so I'll just jump in and say that, for all of these codes, typically these are all the same codes. They weren't made for integrated care, obviously. So the same parameters for the billing codes that you use in a specialty setting are going to apply in this. So probably, Nadia, you should look at the usual parameters for any setting, and that those same rules are going to apply regardless of the setting.
Yeah, no, that's a good point. The one thing I would say that we're beginning to look at, we have not used them other than with psychiatry, are the prolonged service codes. And so if in that specialty setting, it requires a huge amount of chart review, etc., you may want to look at those codes and see if they're in the fee schedule for your Medicaid program, and then see if they're also available for a psychologist. My understanding is they are available for other than medical practitioners, but again, they're new to us.
And that's a great general piece of advice, Mary, is just to work backwards from the payer and what they pay for to the code. Yeah.
Unfortunately, yes.
Yes. Another question here from Ann Daggett. Is it wise to begin to engage in conversations between health systems and local payers to begin talking about the benefits of behavioral health integration in the negotiation of value-based contracts?
Oh, absolutely. That's and probably I should have even said that. Absolutely. I think that, and it's interesting because you want to talk to the large employers as well of the value of integration, because we have impact on the commercial insurers. So you want to have this discussion everywhere. So if you have those forums with those representatives, it's a perfect place. Our organization recently was able to renegotiate some contracts, and we're able to put the health and behavior codes, make sure that those were in those contracts for master's level clinicians. So getting to the right people who have those conversations could be crucial.
Absolutely, and I would say that I think places tend to have more success when they're having a conversation about their whole contract versus just sort of segmenting out the negotiations around behavioral health. So I think the optimal situation is you're really negotiating your whole contract as a clinic, for example, or a system with a payer, and behavioral health is part of that conversation, not the focus of that conversation.
Yeah, and then if you can get a hold of some of that research that talks about overall healthcare savings because of behavioral health and behavioral health integration, really useful at those tables.
Yes. All right, I think we have time for one or two more here. Clarissa Aguilar is asking, what about 96127 for screening and assessment?
Yes, and I meant to say that. It was one of those things that I was reviewing this. I left off the screening codes. On that grid from Oregon, they include some really good information about the screening codes around expert and other things. So yes, definitely look at those. The problem with those codes is they pay very little. And often that screening is part of the initial assessment, and you really shouldn't bill for both. But there might be a time oddly could be a time that you're doing a screening separate from any other work, then you theoretically could bill for it. It's just such a small amount of money and has to be separate from the other work that same day. Right.
So in my experience, a lot of places don't bill that code because they're already billing for that initial visit or the, whatever other CPT code, and that CPT code just bills for more, so it's not worth it. Yeah.
Yeah. And some places may choose to bill both. We have not. Just seems too messy.
Right. Great. Just a couple of points of clarification, and these are just more from me here before we leave here. Just to demystify the whole documentation and billing thing. So the treatment plan and for that initial visit, the requirements you showed, I think you said this, but these are not terribly onerous, or at least as sometimes people make them out to be. They definitely can be integrated into a SOAP note, correct? It's just, you just have to have the right elements.
Well, the first one, and when you do your initial assessment, yes, thank you. If there's a last section on treatment plan, just describe it, really minor. We'll be treating patients for X using CBT for da-da-da. But have it in there. Your actual treatment plan tends to be a template that has all those elements in it that are in that slide.
Right.
And Medicare these days is really looking at that.
Right. So, and then finally, just a clarification that warm handoffs are definitely billable, but they have to hit those time limits, the minimum, of course, which is 16 minutes, correct?
Yes, and they have to, and they often are, if they're going to go that long, that you're doing something beneficial for the patient with the patient, therapeutic. But yes, so yes, absolutely. If you are doing that and it's more than 60 minutes, bill.
Great. Thank you very much. And thank you to all of you who've joined us today. Again, the PCBH SIG has their next call on June 26th, 4 p.m. to 5 p.m. Central Standard Time. Keep an eye out on the listserv and our newsletter for that information. And don't forget to check out our website, integratedcarenews.com, for this video, and we'll be sending through notification of slides and all of that as well. And then we'll see many of you as well in Denver at our annual conference, where you get much more of Mary Jean and others. So thanks again to Mary Jean, and thank you all for participating today. Have a great rest of your day.